All right. Thank you all for the invitation to be here today. I am excited to talk to you about building a career in global health, my past, and what I am hopeful about going forward in the future, in a very unknown future. So I will just caveat it with that. That introduction rings a little differently in today's climate and thinking about what the way forward is than it did in any other time in the past. So I don't have the answers, but I can tell you, I'd like to tell you the things that I'm thinking about and then hear the things that you're thinking about on a way forward. I want to just start with acknowledgement of the unusual time, chaotic time that we are in global health right now, and just do a little temperature check of those in the room. I don't know if you've had a career development talk since January. But it would be great to just hear from all of you, either the fellows on the call, either in the chat, or you could unmute and say just how you're feeling today, if you feel comfortable, where your kind of head is at in terms of global health work. And that might also help me think about other things I might be able to talk through today in addition to the slides I have. So just a brief temperature check of how you're doing today. Uncertain, walking on eggshells. I totally agree. Frustrated. Anyone else? Okay. Well, confused. Yeah. If something does come up, feel free to put it in the chat. Feel free to unmute. Not optimistic. Yeah. Yeah, that's the way I feel too. Just thinking about how can we continue this work if the traditional mechanisms of funding and barometers of success are not barometers of success or mechanisms of funding anymore. Yeah. Okay. I'll keep all that in mind as we talk today, and then this is going to be relatively informal, so please do unmute yourself and feel free to jump in if you have a question or want to piggyback on anything that I say. I'm happy to pause and take this in whatever direction would be helpful for you. So my outline for today is to talk a bit about my own background and motivations in global health work. I'm going to talk a little bit about, for me, what has worked in the past in this global health paradigm of old that we had. And then some of my reflections on what I hope will work in a future global health paradigm for how we can continue to be here to do the work over the next 3.5, 4 years. And then I'd like to close by answering any questions you have and having kind of a broader conversation. So I just want to start by sharing a little bit about my own positionality as a global health researcher and reflect on my identity for you all to get to know me personally and to get to know where I'm situated when I do this work. So I identify as a cisgender woman. I'm born to immigrant parents from Guyana. I was raised in New York City, and I am the first person in my family to receive a university degree. I've lived and I've worked in several countries, including in South Africa, in Kenya, and Zimbabwe for the past decade. And I currently work based in San Francisco on collaborative research projects in these countries. But I do recognize that my position as an outsider limits my perspective, as do the privileges I experience based on where and how I was raised and how others view me. And I'm immensely grateful for the insights from my colleagues globally who have expanded and challenged my perspectives. And these are the faces of some of these colleagues. These are in particular colleagues who were really foundational in getting me into the global health space and building my collaborations and taking me in on their sites when I lived in places in Kenya and places in South Africa and in Zimbabwe. And these are all very much still mentors and collaborators that I work with today and have worked with for a long time. So I wanted to first share my story in academic terms, and then I will share it with you in some more personal terms. So I consider myself an implementation scientist and epidemiologist, and my work is really focused on the intersection of global mental health and sexual and reproductive health for women, with a particular focus on adolescent girls and young women. I have interdisciplinary methods training in behavioral science and clinical epidemiology and implementation science, psychology, human-centered design, and then causal inference and qualitative and mixed methods work. And I gained these interdisciplinary methods through a range of different professional and academic experiences. So I did my undergraduate degree at Columbia University, and there I majored in neuroscience and behavior, and I was pre-med and wanted to go to medical school. I wanted to become a neurosurgeon, actually, which would have been a very different feel of a career path at the moment. Um, and then I was feeling a little bit saturated with all the pre-med requirements, and I started taking some anthropology electives. And that was the start of thinking about ethnographic inquiry and qualitative inquiry and being situated in different communities to really understand local phenomena, driving behaviors. And it was an interesting marriage between my pre-med focus and thinking about some social and behavioral factors driving health of a population. And then worked after I got my bachelor's at Jacobi Medical Center in the Bronx. And that was the start of my journey into HIV and sexual health work specifically. I got a job as a 21-year-old doing HIV counseling and testing in pharmacies all over the Bronx, and then the goal was to identify individuals more quickly in their HIV infection, and then link them to care at Jacobi Hospital, which was a level one trauma facility in the Bronx that serves primarily traditionally underserved populations. And so I did that for a number of years and really fell in love with the public health research lens on things. And at that point, my path sort of diverted from the medical school idea, and I went to UNC Chapel Hill for a master's in public health and health behavior and health education. While I was there, I continued to do domestic work. I was working in rural North Carolina on similar questions of how could we bring access to HIV and sexual and reproductive health services to folks who are traditionally underserved by our medical institutions and doing that in community settings. And then in my second year of my master's, I got a fellowship, which was a surprise even to me, at FHI 360 or FHI, which is a nonprofit, primarily has received USAID and PEPFAR funding and conducts HIV and sexual and reproductive health globally. And so I worked there as a fellow for a couple of years, working on projects around contraceptive technology, HIV prevention, medical male circumcision, a variety of things globally. And that really kind of broadened my perspective and was my first foray into the global health field. I wanted to continue working in global health, and so I went to work at Duke's Global Health Institute. I did not change basketball allegiances from Chapel Hill to Duke, but I did get some great experience working with their global mental health program, which was led by Dr. Kathy Sikkema at the time, and she's a fantastic mentor of mine, and was based partially in South Africa and partially in Tanzania, working on a number of projects around HIV and mental health prevention and treatment for young women. After that, again, to kind of continue this global health focus, I got a job with Doctors Without Borders, and I was based in Eswatini for about a year and a half. And I was the lead epidemiologist on an HIV treatment and prevention of maternal to child health PMTCT program based in Eswatini. And then kind of recognizing that I was hitting the limits of what my master's was allowing me to do and that I wanted to really design and lead my own program of work. I went to the University of Washington for my PhD. My prior experience to that point was very heavily qualitative and mixed methods, grounded in formative work and thinking about study design. But I was really lacking some quantitative skills and some core epi skill sets. And so I chose a PhD in epidemiology to sort of get those hard public health skills that I felt like I had been missing. and continued focusing on the same themes. My dissertation was around questions of how mental health factors like depression, anxiety, post-traumatic stress influence HIV and sexual health outcomes for girls, and then what we can do about it. And the what we can do about it piece led me into a postdoc and where I am now with training in implementation science. And implementation science really thinks about how can we get what we know works to populations that need it? How could we scale it? Um, those types of questions. And so I began asking those as a postdoc, funded on a K, and then still ask those questions to date around bringing uh, evidence-based and integrated care interventions for mental health, sexual and reproductive health to young women globally who need them. So that's my story in the academic sense. And my story in the non-academic sense is parallel, but focuses on slightly different things. So I wanted to just share that with you too, because I think this kind of grounds everything I just said in my own more personal motivations and can help explain why I'm passionate about what I do and why I'm doing it. So I mentioned I went to Columbia and studied neuroscience and behavior and was really interested in maybe becoming a neurosurgeon and working on mental health factors. And that was largely because of experiences in my own family. My grandmother, who's pictured here, had Alzheimer's disease, as did my great-grandmother, as did several other family members, and I watched them go through that. I had also watched several family members go through severe depression. One had experienced suicide. And so mental health factors were really at the fore for me and understanding ways that we could think about preventing them and also kind of understanding what is happening in the brain of someone who's going through Alzheimer's or Parkinson's was also of particular interest. So when I was at Columbia, before I got into anthropology, I was working in a rat lab and I spent many nights and weekends working on rats and mice to try to understand basically cellular pathways in Alzheimer's. So we would introduce beta amyloid plaques, which are a plaque that we see in patients with Alzheimer's in humans, and try to understand in the rat model how cells die and what happens once you introduce the beta amyloid plaques into them to try to think about if there were any therapeutic technologies we could begin to develop to address Alzheimer's. This was again in like 2007. So we're talking a little while ago. And while that was a very rich experience for me and led me to be really excited about scientific questions and the scientific process, I also really disliked working in the animal lab and feeling so far away from humans. And I wanted to get back to that human connection piece of it and feel like my work had a focus at scale that was a little bit more tangible and visible to me. So I was still in the kind of mental health world broadly, and then I graduated and we were in a recession and there were no jobs. And that kind of forced me to really think broadly in the healthcare space about what things I could do, where could I provide unique value, what did I want to do. And that job I got at Jacobi doing HIV testing in pharmacies in the Bronx it wasn't totally random because I did have a pre-med background and I was interested in healthcare, but it was not a job that I would have ever chosen had I had my pick of jobs at the time. There actually was an NIH early career program at the time, and I was a finalist. And sort of similar to today, it was on the chopping block because of a recession and cuts to funding. Um, and so I didn't want to wait around for that and got a job at Jacobi Medical Center and started doing HIV testing and counseling. And one day a week, I got to work in the office and get do some data analysis and think of conference abstracts that I wanted to write and next research questions from the work. And that was absolutely my favorite day of the week. I loved thinking of those public health questions. And while I really enjoyed working with the individual patients, it was thinking about how we can kind of serve a population en masse and think about prevention. That was driving a lot of my interest. And then how I kind of came to this intersection of mental health and HIV and sexual and reproductive health was also sort of born out of that same experience. So I was working, one of the pharmacies I worked at was Leroy Pharmacy. in the Bronx. And there were several times, I think during the year that I was working there, I diagnosed six people for the first time with their HIV infection. And I was able to link, the numbers are a little fuzzy on me now, but I think three or four of those to care. And the two or three patients I was not able to link to the hospital were suffering from mental health and substance use challenges that were pretty pronounced. And basic needs were not able to be met. And so, of course, certainly they were not able to link to HIV services and other healthcare services. And that was this light shining moment for me of these things are not disparate, these things are not siloed. How can we think about bringing mental health care and substance use interventions into spaces where people need them at the same time as we are bringing HIV services into community-based settings? And that has been a key question and focus of my work, starting domestically and then globally for many years. So my overall career goal is really to advance the discovery and delivery of effective HIV and mental health interventions with a particular focus on adolescent girls and young women. I want to tell you a little bit about some of the studies that I work on, just to give you a little bit more of a flavor of what this looks like in practice with the work that I do. And to tell you the story of some of the interventions that we've developed and the things we've been studying, I want to tell you the story of Mary. Mary is a fictional person. In 2016, did a lot of qualitative informative work in a number of populations in Kenya to develop case scripts of typical cases of young women seeking HIV or mental health services. So we went around and interviewed about 40 or so young women and heard their stories, and then used these stories to come up with case scripts of young women like Mary. And these case scripts really just, again, depict what an average woman in Nairobi and Kisumu and Mombasa in Kenya were experiencing around HIV and mental health concerns at the time. So we could start to think about, well, what can we do to address these concerns? So Mary is an 18-year-old young woman. She's living outside of Nairobi. She's in a relationship, and she learns that her partner is cheating on her. She suspects she's at risk of contracting HIV, and she's learned about HIV prevention pills, or PrEP, from a friend and goes to a clinic to receive some PrEP. She's a casual laborer, and she has no sources of income. On a good day, she earns 200 Kenyan shillings, and that money is supposed to sustain her and her partner who doesn't have a job. In addition, her parents who live in a rural area expect her to send money to them every month to support them because they are old and taking care of her son. She feels overwhelmed with her circumstances and has feelings of suicidal intent and ideation. So if we want to think about what we could do to support Mary in her HIV prevention, sexual health, and mental health needs, we can think about reducing one burden on Mary, which is reaching her where she already spends her time. So where does Mary spend her time? She spends her time at home. She seems to go to a healthcare clinic at least occasionally for some things. She might go to school, in and out of school, and she might go to church. And so I have a series, a program of interventions that is trying to reach folks like Mary when they do come into clinic so that we don't give them referrals and send them off to another clinic. We don't add burden to their time, but we try to just meet them where they are and provide them a package of services that they might need in a friendly and tailored and supportive manner. So that case script that I showed you is actually part of one such study. The study is called the Jatunze study. It was based in Kenya. It started in Nairobi, and we're now expanding. And this study seeks to solve the problem that common mental disorders like depression and anxiety are really prevalent among young women who are seeking HIV services, but HIV providers are really struggling to identify and treat them. They're not receiving particular mental health training. Sometimes they might feel uncomfortable opening the can of worms on mental health questions because they might hear about suicidal ideation and intent and then not know exactly what to do about it. But by and large, cases are being missed and care is not being provided because HIV providers are so busy and have not received guidance and training on how to meet mental health needs for adolescents in an adolescent-friendly and supportive way. So we developed a training model for HIV providers called the Simulated Patient Encounter Training Model. We developed those case scripts, and then we trained young patient actors were part of an acting school in Nairobi. They're very good actors, um, in playing those cases. So one young woman actor played Mary as part of our training. And these actors went into the clinics and they provided didactic training along with us on the city team for the HIV providers around how they might be able to counsel and support their patients. And then the actors work with the providers. They basically did mock cases with the providers and presented as a young woman, providers sort of responded how they would respond, and then the actors gave them direct feedback in the moment to say, here's what I like that you did, here's what I wish that you could have done, and we worked through it to come up with a training plan for HIV providers. And then we did a pre-post study to see how our patient actor training model influenced providers' ability to screen young women for common mental disorders and to refer them in an adolescent-friendly way and really link them into services. So this is what our results looked like. It was an interrupted time series design where we collected data before we did our patient actor training and then after on the proportion of young women who were screened for common mental disorders and then referred to care. And we saw pretty low rates of screening for young women like Mary, who clearly were presenting with challenges around mental health, but were not getting screened or referred out for any of those challenges. And then immediately after we did our patient actor training, we saw an 11% increase in the proportion of young women at these clinics who were screened for common mental disorders and referred out, and that trend only continued to increase as we continue to provide trainings and refreshers to providers. So that's one example of the kind of work that I do in clinic spaces. The other thing that we could do is find a way to reach someone like Mary, both in clinic and at home, to sort of meet needs, even if they only come into clinic occasionally. So this is a subject of another study called the CHOMA study, which is the basis of my K99 R00 award, which actually just ended in March 1st. So the problem we were trying to solve here was that evidence-based psychotherapy approaches, like cognitive behavioral therapy, have had limited success with adolescent girls in resource-limited settings, in part due to retention, fidelity, and personnel challenges in providing these things. This work was conducted in South Africa, so moving out of Kenya for a moment. And we took an evidence-based intervention called the Friendship Bench and adapted it for young women in Johannesburg. The Friendship Bench is really nice because it's actually a pretty tight package of evidence-based counseling. It's 5 individual sessions and 1 group session, and it can be delivered by a lay counselor. So we trained a cadre of lay counselors, and we had this whole lay counselor model. And the lay counselors went off and did these sessions in a combination of at homes remotely via phone, and then in clinics, and they also were able to reach out to young women remotely via WhatsApp to provide check-ins between clinic visits. We also developed a number of implementation strategies to affect those things like retention and fidelity and personnel constraints that we often see in this type of service delivery by providing remote counseling sessions, as I said, really providing a support structure for the lay counselors and supervision for them, and then streamlining sexual and reproductive health services at the same time as we were delivering mental health services. So making sure that lay counselor checked in on if any PrEP medication was needed, any emergency contraceptives, any other things like that. And then we studied the effect of this intervention in a hybrid effectiveness implementation trial. A lot of the things I do study not only effectiveness, but also how we implement this package of services to see impact on mental health and HIV outcomes. And the paper is currently under review, and I hope will be published very soon. And then the last way that I want to highlight we might reach someone like Mary is at schools. So again, she might be spending some of her time in schools in addition to some of her time at home. So how can we address those mental health and sexual and reproductive health needs in those locations. So this is the subject of a newly funded R01 of mine that is also based in Kenya, so moving back to Kenya. It's called Adolescent Shama Maisha, and this study acknowledges that individual level services like screening and referral and individual CBT, that's all well and good. But a lot of times mental health and sexual and reproductive health are driven by upstream factors, things like poverty and food insecurity. And so how are we going to tackle those problems that are really the drivers of a lot of these other things that we're just putting band-aids on sometimes? So in this study, we know that incident HIV, STIs, and common mental disorders are high among adolescent girls and young women in Western Kenya. Here we're working in Kisumu County. And those things are driven by upstream structural drivers like food insecurity and poverty. And so we developed a household and school-based intervention to address these upstream factors, food insecurity and poverty. And then we're going to try to see if addressing those factors has a ripple effect on mental health and sexual health among young women. So we're providing these young women and their families with agricultural commodities for their home farms. We are also creating school-based demonstration farms. So at each of their schools, there will be farm plots that they can work on and work on also with their caregivers and their friends to generate crops. They can then sell those crops, and the crops can also go into school lunches at the schools. And then there'll also be caregiver adolescent relationship strengthening training around conversations of mental health and sexual health concerns that happen both in schools and at home. And this study is, we're currently undergoing training and hiring, and we hope to enroll in likely June. It's a cluster randomized controlled trial with 800 girl and caregiver dyads in Western Kenya, and we want to see the effect of the package on adolescent HIV outcomes, food insecurity, household wealth, mental health outcomes, and then look at barriers and facilitators to implementation and see if there are any broader spillover effects to other people in the schools, like other boys, for example, in the schools, and then other people in the communities. Okay, so that's a little snapshot of some of my work. And now I want to talk a little bit about, I guess, my tips and tricks and experiences of what has worked in the past global health paradigm, and then where I'm thinking we will need to go in the future or focus on in the future to make a global health career work. So there are three things that have worked for me in the past, and those are thinking about the passion, thinking about the people, and thinking about the balance. So the passion is really around centering the why for yourself. So I try to be very clear for myself, and you kind of saw that in the less academic summary of what I do. That comes through also in the academic summary, but why I'm doing this. This is not an easy career, and it's only getting harder. And so understanding for myself why this is important to me and why I want to be in an academic institution doing global health work and why I want to be doing global health work, period, as a woman living in the United States. Those are all important clarifying questions to ask myself and to check in with myself often and to center in the work that I do. It's also important to find the people in your corner who support your passion and your vision. So finding program officers, funders, and funding mechanisms that align with my vision has been crucial. I have, for example, at the NIMH, ever since I was an F, I had an F31 and then a T and then a K. So I had these training grants that supported my time. And I found program officers at the NIMH who now are my program officers and R01s who supported that journey and that career path and were my advocates the whole way through. And that really gave me the confidence in my vision and applying my passion to my scientific questions. It's also really important to think about right sizing your projects. You can't tackle everything at once, and you really need time to build up that portfolio. You kind of saw in those three examples I presented. The first one was a super small pilot grant. It was, I think, like $30,000 from the University of Washington. The second one was my K, and then this third one was my R01. So it was really important for me to kind of chunk off where I could things that were bite-sized pieces that would fit within a budget, that would fit within a scope, and also to think about strategic pilot awards that are going to build that NIH portfolio. A mentor of mine once told me, and I think this is really good advice, to think about having a stream of work for yourself that is always some pilot award and some NIH grant, And that way you've got or, other funder, but like an R01 equivalent, so that you've always got the pilot award that's going to feed into the next R01 equivalent, and then the pilot award that can build you to the next R01 equivalent, and you've got your right-sized pipeline kind of building up that way. And then lastly, it takes practice to learn how to write the story to make the case, but it's important to make the case about why this health problem is important, why we should address it now, and why you in particular or your team is the best fit to address this problem. And I always ask myself those three questions whenever I'm starting to work on a grant, a specific aims page, a protocol, and aligning my passion with those research questions. So telling that story and making sure you have, at least for yourself, answered those questions of why this problem, why now, and why me. My team, I think, are really critical starting pieces for then telling that story and translating your passion onto paper. This is how it has looked for me in sort of an academic sense when I talk about translating the passion onto paper and right-sizing things. So this is a overview of the pipeline essentially that I put in my K99. And I just wanted to showcase it to show again that things aren't built overnight, and you really need to lay out sort of an architecture for yourself of where you want to go in 5 years and 10 years with your research question, and then think backwards. And so in building the case for the need for integrated mental health and HIV service delivery, I kind of tackled that from a number of different sides over many years. And this is the compilation of that, which led me to the K99R00 grant. So I studied qualitative perspectives on psychosocial factors and HIV risk among women. Then I looked at similar secondary analyses quantitatively to see associations between mental health and sexual and reproductive health outcomes. Then I thought about, okay, what interventions exist and can we adapt them, and what does that adaptation look like? And then I thought about what are people's preferences and what are the implementation challenges to these interventions. And then that led to, okay, here's an evidence-based approach. I know it would be acceptable. Let's think about how we can integrate it and implement it well in this setting for young women in South Africa. So this is just what the pathway looked like for me. But I had very good support through my career, through program officers and mentors in right-sizing pilot awards to get to this point. The second thing that has been really important to me and foundational in doing global health work has been the people. And when I say people, this might be familiar to you, but it's not one person or one type of person that is to be a mentor. You really need a team of different styles and types of mentors. So for me, that has looked like having folks like the companion, my friends, my people that I could just bounce quick ideas off of. The advocate, having like a high level person who's going to bring you into their network and really advocate and support your ideas with some high up people that you want to get in the room with. The search engine, someone who knows all the things and all the data and can help gut check, is this a good question? Has it been asked before? That type of stuff. The master, someone who like really knows their stuff in that field, knows that CBT intervention, can download it all to me. And then the cheerleader, the person who you just like and you get along with and who makes you feel good when you meet with them and builds you up. And it's important to have a variety of these people in your corner. I think some folks sometimes end up with a mentor or two that fit just one or two of these buckets. And I've tried consciously or unconsciously to have a mix. I just wanted to show you my mix from one point in my career. This is from my PhD time. So my doctoral advisor up here was Dr. Renee Heffron, who, when I was doing my doctorate, was more junior to me now. She had never had a doctoral student before that she was their committee chair. So it was a little risky in some ways, but she also had incredible time and bandwidth and was so thoughtful and was in many ways the master of her domain and was the search engine because she was in such a junior place in her career that she was writing all the grants. She knew all the literature. She was in it. She was willing to kind of back and forth drafts with me all the time. She was sort of my companion too, in some ways, because she was in the midst of writing her own grants and really workshopping things. So she ended up being an amazing chair and primary mentor because she had the time and the bandwidth and was so seeped in grant writing and project work on a day-to-day level. But then I had a co-mentor who was the co-person on my F and my K, and that was Dr. Connie Kellum, who in many ways is the advocate and the cheerleader and also the master, who is very senior in her career and knows everyone and was able to connect me with all of these people and was such a staunch advocate for my work on a different level. And that was really incredible. And then Dr. Sinead Delaney-Moretway, who is one of the heads of research at WITS, RHI, University of Witwatersrand in Johannesburg. She was many of these things also, but in particular, also the kind of master and advocate on the South African side and really took me in and had me be part of her team and introduced me to people at the Department of Health and really connected me and paved my way there. So that's what it's looked like for me. And, mentorship doesn't have to be a straight line. You don't have to continue mentored relationships with folks for a very long period of time, but it's helpful to think about your balance. Also, just a word to say the people includes, for me at least, a community advisory board and community groups and thinking about who my key stakeholders are. So with every project I've done, I've had a community advisory group, sometimes many in the case of this project where we had 5 different community advisory groups. It's a large project, it was necessary, but I wouldn't recommend it. But thinking about who your community stakeholders are and can you center their voices in your work and make sure that they're buying into your passion and also being champions of that and you're being champions of their passion and voice as well is important. Okay, and then the last thing is the balance. This is something that I'm sure everyone here struggles with and will continue to struggle with no matter how senior they are. But, that work-life balance that's so elusive, the balance also in tasks of what you're doing on a day-to-day basis. Things that have helped me find that balance are individual development plans, IDPs, where I'm really forced to write out what are my 1-year goals or 6-month goals, what's my 5-year plan, and sometimes even what's my 10-year plan roughly. And that just helps me think about where I want to go so that I can work backwards and make my to-do list. So if I've written out my 6-year plan, my 6-month plan, it's relatively easy for me to then look at my calendar, look at my to-do list and think about, well, what's not serving me in this 6-month plan? What's not going to get me to where I need to go? And how can I be intentional and protective with my time to achieve those 6 monthly goals? One way to do that is something like this, to kind of bin tasks by urgency and importance. I've actually done this where I've gone through my entire to-do list or my entire kind of calendar and put things on a weekly basis, every Monday morning into one of these buckets. What's important and urgent? Okay, I got to do it now. What's important but not urgent? Can I schedule it out for a week from now, 2 weeks from now? What is not important but urgent? Who can I delegate it to? And then what's not important and not urgent? Let's just get it off the to-do list right now. And if something changes, someone will follow up, and that's how I will handle it. It's also important to have a reflection for yourself about what you need in your career right now. So is it publications? Is it grant funding? Is it new collaborators? Is it teaching time? I think of my year in kind of seasons and quarters. I often tend to have a grant writing quarter and then a publication writing quarter and then another grant writing quarter and then a publication writing quarter. It doesn't always work that way. And of course, I'm doing other things in those quarters, but there's a season of 3 months where I'm heads down trying to get a grant in. And then there's a season of 3 months where, because I was getting that grant in, I neglected all my publications and I really need to get some publications out. So let's do that. And I try to just bin things that way. And that makes a little bit more structured for me. I also set up a regular writing practice. This is just an example of what that looks like on my calendar. I block off time and I'll put the manuscript that I want to work on. I'll put in my calendar any attachments, so it's just easy for me to find, or a link in box to where I need to go. So I don't even have to think about it. I've got 30 minutes. Let's just write those 30 minutes and get it done. So I'll often put like hold manuscript intro paragraph 1 and then a link to what I need. Hold, I'm working on a grant right now, hold the space for writing the grant, and then I'll put my to-do list of what I specifically want to work on that day. And then it's also important with this kind of thing to think backwards and build in time for peer review, CAB feedback, other review mechanisms. Okay, And then lastly, this is my 19-month-old daughter, Caroline. It is very important for me to have the balance right because of a lot of things. There's just a desire to spend time with Caroline and spend time with kiddos. There's also the reality of hard stops for daycare pickup and drop off. There's also the fact that I am never 100% at work anymore because my mind is always going to be at least partially elsewhere, thinking about Caroline, getting daycare updates from what's going on with her, scheduling her pediatrician appointment. That's just a reality. And then I am always also going to be somewhat less reliable than I was before because of illnesses and sleep deprivation that I do not have control over. So all of those things mean I am not going to be my 100% most productive self. And that's all the more reason to have that balance, right? So again, I sort of plan my week in advance. Every Friday or every Monday morning, I'll think about my to-do list for the week and put it into those four buckets, scratch off things that don't need to happen, push out things that can wait, and block off my calendar, as you saw, to try to be really intentional about like, this is actually what I could do in a normal work week. And all these other things are not going to make the cut, and that's okay. Can I delegate them or remove them or just push them off for another week? Also, it's important for me to negotiate with partners, sitters, family around work blocks if and when I do need them, if it does need to butt up against after work hours. I try to simplify other aspects of my life when possible. Can you order some takeout? Can you um, do something to make a commute easier on yourself? Can you take a call in the car? Something like that. Exercising my no muscle. So I've started since having Caroline, starting from a place of no, which is new for me. Um, and then only saying yes when I really take a moment. I always take a beat. I say, can I think about this? Can I take a week? Can I get back to you? And then I think about, does it align with my why, that passion question? Does it align with what I need right now? Grant funding, publications, collaborations. Um, and can it wait? Can I budget it out in my 6-month plan? Because I'm booked for the next month or two, and it's really hard for me to accommodate urgent requests. So I can do this, but it's going to take 3 months from now or something. So being really honest and intentional with when you can fit it in. And then lastly, doing global health work means sometimes you're working at odd hours. And so sometimes you just need the break during your workday. If I'm up from 6 a.m. on calls, I'm going to take a time to go for a run at 10 a.m. and just give myself that mental break and feel good with that, or stop working at 3 or 4 to spend time with Caroline and feel good with that. So it's all about that balance too, and acknowledging all the other hours that you are working that are not part of a traditional workday. All right. And then lastly, some very quick notes on what I hope for the future. And then I'd love to hear from you all. I don't have the answers. These are just things that I'm thinking about in real time that are helping me in the chaos and uncertainty of it all. So again, centering around the passion, the people, and the balance. For passion, not much has changed on the why for me, but what will have to change is identifying those new non-federal funding sources. So who are the new program officers? Who are the new funders? What are the new funding mechanisms that might align with my vision? It's also going to require a little bit of restarting on the networking front to identify new opportunities, and more time now when I wasn't expecting it to build up a new portfolio. So what things I have to kind of ask myself, actually taking a step back from my passion for a second, how can I keep myself funded right now to keep myself in the game in this world so that I'm here and ready when and if things do change? How can I keep myself afloat? Do I have to teach more, take on some other things that I didn't anticipate? And then, okay, take a breath. Where am I going to apply for my next funding sources? Are they foundation fundings, pharmaceutical fundings? I'm here. I've got the funding to last me through the next 9 months, year. What things can I apply to that align with my passion in that time? I also think it's going to require more of a balance of breadth and depth. I know that traditional advice is to, go deep in a topic when you're junior and to stay there, but I wonder if we need to be a little bit more creative around uh, tackling a health problem from a place of more breadth than depth, just to kind of stay afloat in this uncertain environment. All right, and then around the people, um, I think the mentor model remains the same, although it's going to be about finding the advocates and the new people in a new model of global health work. So finding your partners in pharma, finding your partners in foundations. So who are those folks who've gotten those sources of funding and can advocate for you in those spaces and introduce you to the right people? That's a bit new. Um, I do think, for myself at least, I'm excited about maybe embarking on some career coaching. I think it will be helpful to think about other ways to do this kind of global health work that are not the traditional academic model. Changes to this funding model also may mean fewer shared resources. So, depending on what happens with indirect costs, it might be more of like each individual team has to support their own grants people, their own data people more than we had been working before. That might require some leadership or management training. That might require thinking about a group of colleagues that you could share resources with and how the institution you're a part of and the team you're a part of can protect and support each other, um, with creating some interconnectedness there. And then the last point on the people is just the collaborators that I work with globally and locally. We really just all want transparency, and we can't provide an answer, but I think what we can provide is what we know now and what we're hoping and what we're going toward. And so I think just maintaining open lines of communication and transparency and empathy and kindness on all sides is going to be really important in this new climate. And then lastly, for the balance, same as what I said before, even more emphasizing the importance of work-life balance. Some things I'm trying for myself are protecting my mental space, after a certain hour of the night, turning off the news, taking a break from social media. Writing time feels all the more critical because I don't know what tomorrow will bring. I really want to make sure that the work I have done is going to get out there and get published. And I also want to make sure that I'm setting myself up for this new kind of potential funding model with advocating about the results of my work and directions that we could take. So getting it out there in website forms, just different dissemination approaches, I think is going to be really important. Kid time can be very centering, even though it's hard. And I do try to embrace that rather than seeing time away with my kiddo. She's currently home with COVID right now, but we are saying that this is a break time for me to recharge and get a little bit of time and space with her. And really, I'm just trying to ask myself the question. I don't have an answer, but how can I continue this work while also protecting my own peace and peace of mind? And so thinking about how to do that is going to be a really important centering question for me going forward. Okay, that's all I have. I'm happy to take questions and yeah, continue the chat. And also, if you want, I'll put my email in the chat if anyone has any additional questions you want to follow up about at any point.
Thank you. Thank you so much. That was wonderful. And this is exactly what we need during this current climate. And, I'm really inspired by your work and your framing. And I think I'm sure our trainees have some questions for you. Um, yeah, feel free to type it in the chat or you can unmute yourself. Let's see, we have at least 5 more minutes. Uh, Yeah, I really like the end piece where you're kind of thinking about how we need to pivot. And, I think many of us, including myself, I think thinking about alternative funding strategies, I think it's really key. And then one question I have about like your passion piece, I think the way you framed it was really excellent. So I think in the current climate, I'm struggling with how do we do the work that we're passionate about and reframing it without compromising our core values? And sometimes that's really hard because, like, for example, you know, I do a lot of work with LGBTQ plus communities, transgender communities, and like if they're not part of, the study, I can't recruit them. Like, how do I continue to do those work? Um, and get it funded and kind of um like so yeah, that's my like first question. But
Uh, I I wish I had a good answer for that. I've been wrestling with the same thing. I am very torn between uh yeah, feeling like I'm compromising my values versus feeling
Mhm.
like I'm doing what's needed to do some part of the work.
Yeah.
I'm having trouble drawing that line for myself. I think the way I've been thinking about it is sort of what I was saying on one of the last slides that so I'm it's all unknown what's going to happen, but a large portion of my portfolio is in South Africa. So just take
Hmm.
that as an example.
Right. Right.
So I'm thinking about, depending on what happens with that,
Hmm.
what types of things can we do now to keep teams funded, to keep pe personnel funded, to keep our group afloat?
Yeah.
Myself, my team at UCSF, our team at Wits in Johannesburg, our community advisory group, like how can we keep all of these people safe and somewhat protected?
Hmm.
And that first question does seem to require some of what I would consider essentially a compromise of
Yeah.
my passion.
Yeah.
Um, and the only way I can make it make sense is that I'm saying, well, but it's also for the sake of keeping the continuity of a team and keeping staff on
Mhm.
and making sure that we'll all be here to do the work when we can figure out another way to get this work funded.
Yeah.
And then at the same time, I'm trying to figure out what foundations, what donors, what other places will fund the work as I want it to be funded, as we all want it to be funded,
Yeah.
um, in a way that truly adheres to our passion and values. And so I'm hoping and wondering if it's going to just have to be some combination of those things in parallel and making sure that we are clearly understanding when we are making compromises to our values and passion and language.
Yeah.
What is it for? What is it in service of?
Right.
And is that worth it? Is it
Yeah.
in my case like in service of a team staying afloat, and is that worth it? I think yes, in that case, in our specific example from conversations I've had, but any team can make a different decision.
Yeah, thanks. And I think Kelly had the same reflection or thoughts about
Yeah.
um yeah, Kelly, you want to expand on that?
Yeah, I've been I submitted a presentation to AIDS Impact, and we're looking at uh, peer counseling intervention for MSM, and then there's a sub-study for trans women, and working on the paper and wanting to turn it into a next grant application, and knowing it's not going to get funded, but so our team has been having these conversations about how to, changing language like everybody else, and the same conversations everybody's having. And then the idea that I don't know that I want to go forward submitting a paper that I have to compromise
Right.
language and hide a community. It's
Mhm.
it's just it. I don't know that it's right, and I'm not judging anybody that makes that choice. I just feel
Mhm.
like I don't know if I can do it. And so it's just, we all have to kind of face these questions.
Yeah.
Yeah. Yeah. I hear you.
Yeah. I mean, it's a really difficult situation and hard balance. And I think all many of us are kind of right now reacting to this constant attack on the work that we do. And of course, like, yeah, all of us, including our institution, we're like rebranding our Justice, Equity, Diversity, Inclusion Office is now called Office of Inclusive Excellence. But, I think we need to have a long, like, kind of looking forward, like, what is our long-term framework and goal? Because I think right now we're kind of in shock and we're just doing everything we can to just move along. But I think the long-term plan has to be much more intentional and consistent with what we want to do, on an ongoing basis.
Yeah.
So, well, Jennifer, I really appreciate your time and thank you for your wisdom. And I'm glad that this is being recorded so we can, kind of learn from your experience in the future again. So, and thank you all so much for being here. And I wish you the best rest of your day.
Thank you all.
All right.
Thank you.
Any updates or announcements for the trainees?
No, I don't think so.
Okay, great. All right. Thanks again.
Bye, everyone. Thank you.
Thank you,
Bye,
Catherine.
everybody.
Thank you.